Hello everybody, my name is Oliver Bozinov. I'm working in St. Gallen, Switzerland now. I've been working in Zurich for many years, and I was invited to give a talk about our analysis of safe entry zones into the brainstem in different pathologies. Thank you very much for this kind invitation. This is definitely something that I love to talk about. So we'll go to the first slide, and if you look at this, where we show all the tumors in the CNS, you see basically that a very small amount, only 2% of tumors are in the brainstem, and of course there are other pathologies as vascular, etc. But nevertheless, the brainstem is just a small region where tumors occur, and certainly any kind of surgery is difficult. Now, we had in Zurich many courses and conferences on brainstem. As you can see, even this international conference is in 2019. Now, as you also all know, with Corona, for the last 1.5 years, we didn't really have a chance to meet and talk about advances in our techniques in brainstem surgery. So I'm very happy that I got invited to give this talk and that we continue to share our experience and knowledge of brainstem surgery. And I really hope that in the near future we will have some courses again and see each other. Now, if we start, we will talk about brainstem surgery. The cases of cavernous malformations are always very helpful because we learn so much from this disease and those surgeries. And there are basically 3 big groups that are summarized here. The first one is the Spätzler patient group with large series, which has now over 400 to 500 patients, but in 2011 260 were published. The second group is the one from Helmut Bertalanffy, my teacher for brainstem surgery, and the third group is the Milan series. And you can see that basically an overall mortality rate is around 2%, but still all groups had some new deterioration or neurological deficits. So it remains a very risky surgery, and thus we need all the information and all the knowledge that we can share to master these surgeries. I come back to the first group of Robert Spätzler, which I visited also in 2002, and I consider him also one of my teachers. He had a very typical, simple way of explaining a safe entry zone, and he pointed out this so-called 2-point concept, meaning that you take the center of the lesion and the nearest point to the brainstem, and that trajectory would basically help you to find the safe entry zone. Well, this really helps for the approach, whether you use a suboccipital or bilateral approach, but it certainly does not help you to choose a safe entry zone into the brainstem. It's just the closest entry to come into the brainstem and into the lesion. But nevertheless, it's the largest series that we know of. So regarding cases, the experience of Dr. Spätzler is certainly huge, and all his recommendations should be heard. So we should think about this concept as well. The moment when I started to think more about safe entry zones was basically the publication of those 2 manuscripts in the same Journal of Neurosurgery issue. And one group again comes from the Spätzler group, one publication, and the other publication also from the famous Evandro de Oliveira group. And you all know that our teacher Evandro de Oliveira just recently died, so we really need to remember him. He made a big difference in anatomy thinking, and he helped teaching a lot. I saw him on many courses, and I learned myself a lot from his lectures. Now, both groups, the Brazilian and the American groups, they were talking about the same thing, basically the safe entry zones into the brainstem. And if you look at this slide, I took the pictures. Fortunately, both of them took the pictures with black background. And but you don't know now which publication showed which entry zone. However, for the lateral mesencephalic sulcus, both publications had basically an agreement. Also for the olivary zone. For the colliculi, there was a disagreement, as the one group was, the Brazilian group was definitely advertising superior or inferior approach of the colliculi, and the Phoenix group advocated a medium transcollicular approach. Honestly, I was very surprised, as I also learned from my teachers that this is a very bad choice, as there are connections between left and right superior and left and right inferior colliculi, and patients have difficulties later on, and they have a significant double vision. However, I confronted Dr. Spetzler with this, and he actually said that he would not recommend this approach, which was kind of sad because they just published it 2 years earlier. Anyway, so there's no disagreement, and again there's agreement again on the median sulcus, so straight midline approach through the brainstem. So this conflict basically led us to evaluate and to look for all the so-called safe entry zones in the brainstem in the literature. And to do so, we basically defined 3 levels. So the first level are the case reports. So when we have only less than 5 cases or anatomical descriptions, we considered limited evidence if the case number was between 5 and 25, and credible evidence. So if there's a series with more than 25 cases on one safe entry zone, then we do have at least some eminence-based and credible evidence. Now, we will never find randomized controlled trials or something like this with level 1A, 2, or B, or 3 evidence, but with all this experience in the brainstem surgery, we will have to stay in the lower level of evidence for treatment. Now, if we look at the results, again, we have 27 publications with 21 safe entry zones that were described, and you can see them all here, again, with the colliculi approaches, with the midline approaches, mesencephalic lateral approaches, olive approaches, and also very importantly, the suprafacial approach or the infrafacial approach. Now, again, if we take all the case reports out to take the very low evidence out, in this slide you can see that now only the more bigger case series and numbers are described, and many of the safe entry zones are not included anymore. And if we take out the mid-range, the clinical case numbers from 5 to 25, we will basically end up only with midline approaches or paramidline approaches, as you can see here with supracolliculi or infracolliculi approach, with a facial, suprafacial or infrafacial approach, and the with the medullary sulcus approach. That this one had over almost 50 patients, but only one center. So this is a single center retrospective study, and it's not confirmed by other centers. Maybe and most likely many others do this approach, but they have not published it. But if more centers have published the same approach, like you can see on the superfacial or infrafacial approach, where 5 to 4 centers have published it, now this gives us much more evidence, because it's a lot of cases, or it's at least, compared to the other ones, it's a lot of cases, and we have different centers confirming it as a good approach. So this gives us more hope and more confidence to use these approaches. and we listed all the other ones. As you can see, most of them are single center, or 2 centers have reported this approach. So only 28% of all the safe entry zones we have up to 3 centers that describe it. Now coming back to the midline, I've told you that many publications, or the most of the publications and the higher number, show the midline approach, either through the through the floor of the fourth ventricle. However, in all the old anatomy bookmarks, we also know that there are some connections between the colliculi and the nuclei, between left and right. So a pure midline approach can still do some damage. I personally believe that the midline approach comes somewhat from the spinal cord surgery, where the least damage is done through a pure midline approach. However, in the floor of the fourth ventricle, it's much more difficult to do it. And a very important work here from my teacher, Helmut Bertalanffy, which was published in Neurosurgery at those days, is the inter and intra-patient variability of the facial nerve response areas in the floor of the fourth ventricle. And you can see now here on the left side, you see this should be the anatomical optimal position of the facial nuclei, as you can see here. And this is the fourth ventricle, as you see, with the obex in the bottom, and on the right and left side the Luschke. Now this would be ideal, so everybody would expect that. So now how do you decide to go supra or infrafacial of this nuclei? And just the anatomical or the measurement would definitely not help, as you can see from this study, and it shows it very clearly. So take this middle graph, and you see now in the A, you see all patients that were normal, so no deformity, no tumor, nothing in this area, so normal anatomic patients. And you see every color is a different patient. So the blue one is a different patient, the green one is a different patient, the red one. So with electrophysiological stimulation, he was able, I was a little part in this paper, but it was definitely Bertalanffy's idea, and he was able to show that the variety of the nucleus is much more different than we thought. Sometimes it's much bigger, sometimes it's smaller, and there could be a centimeter in difference of this nuclei, and this is in healthy patients. Now, B are the patients where the tumor is basically not in the brainstem, but compressing, but doing some kind of relocation basically. And you see now the variety that the facial nerve, for example, in the green patient goes even up to the top, and the blue patient is on the bottom. And now if the patient has really a cavernoma, for example, in the brainstem, then the variety is totally basically crazy, and you cannot predict anymore where the facial nerve is. So basically the conclusion of this paper, without any kind of intraoperative electrophysiological monitoring, you should not just assume where the facial nerve is, because you most likely will destroy it. So coming back to the safe entry zones in the midline, even Bricolo in his books in the late 90s did not recommend the midline approaches because the outcome was very bad. But unfortunately, this information has lost somehow. So in our future publications and recommendations from our group, we first thought about a new classification, meaning that if a lesion is purely midline, as you can see here, the risk of damaging both sides is very high, and thus the outcome might be really bad. Whereas if a lesion is very lateral, as you can see here, then those are more prone for resection. And I think as a neurosurgeon, you are much more motivated to take out this lesion. So we basically divided it into 3 zones to score at later on those outcomes and the location. Now, a project that we are running right now is the brainstem stimulation project with my fellow Yang, who also helped me with these slides. And we use this very important information again from the group of Bricolo and Francesco Sala, who was helping a lot in this here, is to detect the cortical spinal tract, to map it in the brainstem. And you see different protocols were used, but basically with 2 milliampere the brainstem was stimulated. So it's definitely too much for the facial nerve or for the nucleus, but for the cortical spinal tract you do need some more power. So with this 2 milliampere and 0.2 milliseconds and frequency of 3 to 4, we use 3. We are now currently mapping the brainstem for the cortical tracts, and you see these are the works that we used for it. And when we have a tumor, you can see it here. So before we enter and before we destroy or damage the cortical spinal tracts in the tumor resection in the brainstem or cavernoma resection, we stimulate the brainstem and try to detect the cortical spinal tracts. And I hope at the end of the year we will have enough patients to finally publish these results and share them with you. So again, as you can see, intraaxial lesions. The patients, of course, have to be over 18, have a lesion in the brainstem suitable for brainstem surgery, and of course, consent to this study. We are collecting the exact stimulation points, and we are actually thinking now about multi-center trial now with our experience that is very solid to also combine other centers in this. One last thing, how we do it. What do I call a safe entry zone? I think the transpeduncle entry zone is very good. Why? Because they are pontocerebellar fibers. We do not have any nuclei in this peduncle, and any approach through this lateral side is, in my opinion, a favorable approach because it's rehabilitable. And I will show you how we do it. So it's a supracerebellar lateral supracerebellar classic approach, infratentorial. You can see release some CSF. If you have a bridging vein like here, I like to put some fibrin glue on top of it. This is a trick that I learned from Professor Bertalanffy, which is very good, so the bridging vein does not rupture. And now going supracerebellar, infratentorial, I'll go to the navigation. I go to the point where I want to enter the peduncle, the cerebellar medial peduncle. And now you can see here with the navigation, I'm close to the cavernoma, and I decide to incise here, as you can see. And then I pull out a piecemeal technique, some cavernoma pieces, and of course resect the tumor or tumors. So this is, in my opinion, a very favorable approach, as you can see here, the resection, and all without any kind of retractor, piecemeal technique. You take out this cavernoma. So one case, as you can see, 2009, this cavernoma, definitely not worth it to be operated. Controlled 2010, patient was doing well. In 2013, yeah, many people could say expected, you should have operated her in 2009, but she was doing very good in 2009. In 2010, why perform a surgery? Now the cavernoma is much more to the outside and much more resectable. And as you can see, we chose a transpeduncle approach from the right side, and the patient was doing fine. Now, very important last message that I want to give you is that if you use a transpeduncle approach, you have to be very careful not destroying or not injuring the supracerebellar peduncle or the inferior cerebellar peduncle, because those are connected to the Guillain-Mollaret triangle, which is a feedback circuit and the modulation of spinal cord motor activity. And if this one is damaged, there's some olivary damage too. And these patients, they cannot rehabilitate So such a damage is really devastating. So stay away from the midline, from the medial parts. Please come basically from lateral. So I thank you very much for the attention. I'm certainly available for questions. Thank you.